So Dr. Liu from NTU Hospital is going to be giving a presentation on her research. Everyone, please give your hands together. Dr. Liu. All right, and after...
The post is better, actually.
Yeah.
The post is better, yeah.
Okay, good morning, everyone. I'm Dr. Liu英文from the NTU National Taiwan University Hospital in Taiwan. And I'm proud to be here today to share with you our research results in the non-intubated thoracoscopic surgery. And our hospital is one of the leading groups in doing the thoracoscopic surgeries as well as the non-intubated thoracoscopic surgery. And I'm here to share about our latest and a simple, fast, and efficient way of doing this surgery. Let me start by giving you some background knowledge of our research. Traditionally, non-intubated thoracoscopic surgery, aka also known as non-intubated VATS, is done by thoracic epidural anesthesia, and it's a safe and feasible way to do that, and even in complex procedures such as lobectomies or segmentectomies. However, thoracic epidural anesthesia has its own drawbacks. It is time-consuming, it is skill-demanding, and most of all, it can cause rare and devastating neurological complications. Therefore, our purpose of our study is to compare the intercostal nerve block with the thoracic epidural anesthesia in doing non-intubated VATS. Okay, moving on to our methods, how we do this procedure. We do the intercostal nerve block by using the standard monitor. We use the bibistral index monitor to monitor the anesthesia depth, and we use target control sedation to put the patient asleep. We also use capnography to monitor the respiration of the patient. During 2009 to 2013, we evaluated about 205 patients, both in the thoracic epidural group and the intercostal nerve block group. And you can see these are the pictures we took from the surgery. The intercostal nerve block is performed by a surgeon after the thoracoscopic surgery is started. And to prevent coughing, we do the vagal nerve block in both groups. Okay, what's our results? Our results shows that the intercostal nerve block is shorter in the anesthesia induction time and the surgical duration. Both groups have similar preoperative parameters, such as the highest end-tidal CO2 value and the lowest oxygenation saturation. And we also found that in intercostal nerve block group, the patients have more stable hemodynamic status and lesser use in vasoactive agents and less total fluid administration. What does this tell us? This tells us that intercostal nerve block can provide a feasible and safe as the thoracic epidural. Add on that, it is also safer because it avoids the complications that thoracic epidural anesthesia might cause, and it also can avoid the unstable hemodynamics after the epidural anesthesia. So, in conclusion, it's a safe, faster, and simple methods to do in doing the non-intubated VATS. That's my presentation, and here I open the floor for questions. Is there any questions? question. Then we often ask ourselves about that. Actually, we got monitors of the respiratory rate and the hemodynamic. We have the arterial line to monitor blood pressure. So before the surgeon has to perform the first surgical hole for the video scope, they will perform the local anesthesia for that. And after that, we can monitor the respiratory rate and the BIS monitor and the blood pressure to know if the patient is under enough anesthesia or analgesia. So we will keep the BIS monitor between 40 to 60 and try to, if the analgesia is not enough, we'll add a little fentanyl to facilitate the procedure of the procedure. Am I answering your question?
So you mean that the effective concentration for the target station is less after the intercostal nerve blockade? Or else will be the same?
We try to keep the depth the same, and after the let me clarify your question. Do you mean that after intercostal nerve block, the depth of anesthesia is higher or lower? Is that your question?
No, I mean the concentration to the target base level. Is it higher or lower? Or it did not change?
I don't have enough information with me, but I think it's in my experience, I think it's basically the same before and after the intercostal nerve block. But after the block, the requirement of the preoperative opioid use is less.
其实它会降低。
真的吗？
真的。
Is that correct?
No,
那我会乱回答，对不对？
Yeah, the effective concentration is lower
Okay.
after the block.
Okay.
I just tell her,
Yeah. Okay.
help her to prepare.
Yeah. Okay.
So
Oh,
you-
okay.
So you can read on the monitor the target concentration is
It's
lower.
lower.
It's lower. Okay.
This means the local anesthetic work.
Good. Yeah.
真的真的。哦。
就
会，
combine
必须会下降。
TCI 的
TCI
concentration 可以降低。
就是 combine balance anesthesia，你其实 component 会下降。一个有效的 opioid 你可以，就是你一个 effective 的 anesthesia，你的 sedative drug 就会需要。
对嘛哈？
他是要
是嘛哈？
你刚是要问题再帮他回答。
对，我刚是问他问题，让他可以做一个。你干嘛照我？
Is there any other questions?
Any other questions?
Do you guys have 3 more questions?
block 之后 TCI
Let's go.
Maybe
One question frequently asked is how is this a safe method? Because as you can see here, the vagal nerve, especially when we are doing the left side mass, it was very close to the aorta. And my answer to this question is because we use target control anesthesia with the BIS monitor, so we can monitor the anesthesia depth. And when the anesthesia depth is stable and the surgeon can see where they are going to injection, the procedure is safe to do that. Yeah.
Dr. Liu, may I ask a question?
你先问，你先问。
May
May I ask a question?
Please.
When you talk about the result, you mentioned that in the intercostal blood group, the anesthesia induction time and the surgery time will be reduced. But my question is, the reduction in anesthesia induction is reasonable, but I don't understand why the surgical time will also be reduced in the intercostal blood group.
Yeah, and actually I'm thinking about this question a few days ago.
这个太泛滥了啦！这个回答太泛滥了，我觉得这个答案很直接。
And that is a very good question because I asked my colleagues a few days ago. And yeah, I think you're right because we all know that if we skip the thoracic epidural, which is very time consuming, we will reduce the anesthesia time. But I think the reduce of the surgical duration has proven that the intercostal nerve block is not difficult for the surgeon to do. So they can do it very efficiently without delaying their surgical procedure. So maybe the question itself answers what you asked before. It's not. One way to think of the question is that it is a very easy way for a surgeon as well, and maybe we can try to do more case to see if the duration will increase or even less after we expand our case number.
啊？对啊 I think you
describe why the
It's not longer, but
surgery time is not longer, but that's the answer why
why
it's
it's
shorter.
shorter?
In my opinion, maybe if you can say that possibly the intercostal nerve block group is I don't know, maybe better anesthetic effects or analgesia effect. So the movement of the diaphragm or such that the respiration net is better for the surgeon to do the surgery. Do you think it?
Are you answering for me or you're asking a new question?
Yeah, he's trying to help you.
And sometimes the audience will recommend your possible examination, so that's their contributed comment to your study. Yeah.
Yeah, I think it's a very good statement of why the surgical duration is lower, but actually it's hard to develop a parameter of how good the surgical exposure is, and if we don't have that, we cannot compare between the two groups if there's a better surgical exposure or not. So I think it's a very good explanation and a way to find out how exactly why the duration is shorter. Maybe we have to do work more on that.
My suggestion is that your group are using intercostal block after you accumulated nearly 130 cases of non-intubated thoracoscopic lobotomy using thoracic epidural anesthesia. So the technical of your group have improved a lot, and maybe you select your patient.
Yeah.
You get familiar with the technique, and you have improved criteria to select your patient. Also, it's also reflected in your result in the costal block that the conversion rate to intubation is improved a lot. That seems reasonable to me. 我的回答是这样子。
I would say because of the stable blood pressure and stable respiration, so the surgeon can proceed their procedure, continuously. That's why the operation time is shorter. Because they don't give us time to manipulate the blood pressure or something else. If we should get many drugs, or the surgeon will stand there waiting for us to do it.
But they don't take time to give drugs. That's you anesthesia doctor do. But you can incorporate those suggestions.
Can I do it again? I think the reason why the surgical duration is shorter is because first, it's an easy procedure to do, so it's not longer. It will not delay the surgeon for proceeding their procedure. The second reason is because of the more stable hemodynamic status of the intercostal nerve block, and because if the surgeon wants to start manipulating along the open pneumothorax, and their manipulation will further cause the hemodynamic instability. So they have to wait for anesthesia to do the lung expansion or the vasoactive agent to stabilize the patient. So maybe it's a part that delaying the surgical procedure.
Okay.
Well done.
So I think maybe everyone, if you wrote down questions, maybe everyone can give their question to Athena after, just so she understands your thinking.
不要录。